Hi everyone, today we're going to be talking about the problem of symptom reduction. So we're here today to talk about the problem of symptom reduction, and there are a number of therapies, particularly the kind of contextual cognitive behavioral therapies or the third wave therapies, which are really not overly focused on symptom reduction as their goal, which is sometimes a little bit confusing for clinicians to kind of get their head around. But it's an important kind of topic for us to look at, I think, to have an appreciation of why we're kind of potentially not focusing all of our efforts towards symptom reduction in therapy. So it's very easy for clinicians to become caught up in working towards symptom reduction with their clients. It's been a huge focus in psychology. A lot of the research into evidence-based practices and randomized controlled trials have basically used symptom reduction as their outcome measure to justify why something is effective. So it's an understandable kind of a goal for clinicians to be working towards. There's also a very natural appeal to it, of course. You know, we see our clients in distress and we do want them to feel better. So it has a very natural kind of pull towards it in therapy. So there are a number of reasons, though, as to where we can run into problems when we sort of are solely looking through that lens of symptom reduction as being the outcome that we're working towards in therapy. Some of those problems are kind of philosophical in nature. I mean, even the fact that we use the word symptom, using the word symptom is kind of really not consistent with the contextual worldview. In contextual worldviews, people don't have symptoms, they have experiences. They have experiences which we might then label as symptoms, but that's a completely separate kind of act on its own. So really we see all of people's kind of behaviors or emotions or thoughts as being experiences that they have that all have a situational and historical context around them. So we don't think about behaviors or emotions or thoughts as being symptoms. But because this is so ingrained in the language of kind of clinical psychology to see these things as symptoms, that language is also kind of grounded in what's connected to symptoms, because we all sort of have a history around the fact that symptoms are bad things. And we all kind of have a sense of like, well, what do we need to do with symptoms? We need to get rid of them. That's kind of how to correct pathology, which is kind of true in the medical model or in a kind of mechanistic worldview of correcting pathology, but it's really not consistent with our philosophy in kind of contextual terms, where we want to make sense of our experiences and the context that influence those without kind of labeling them as symptoms or seeing them as caused by some pathological kind of process. There's also problems in symptom reduction as being the goal in terms of symptom reduction is sometimes a misleading goal to work towards. So there are things that can happen in your clients' lives or things that they can do which might result in symptom reduction. So it might result in a reduction of their anxiety or a reduction in other levels of distress or a reduction in kind of certain types of thoughts. But not all of those things are necessarily synonymous with kind of getting better or living better. Life circumstances might change that just naturally produce a reduction of symptoms. People might kind of start engaging in more avoidance behaviors, which might kind of, initially look as though their symptoms are coming down, but may not necessarily be playing out well for them in the long run. In saying that, when we see symptom reduction as being the guide towards successful therapy, it might also mean that if we see symptoms exacerbating, so if we see people getting more anxious or more distressed, that we might immediately assume that that's a bad sign, that they're actually not improving. However, there are circumstances where improvement actually goes hand in hand with symptom exacerbation. So you might be working with clients who maybe have been sort of dissociating for a long time or are in some other way kind of disconnected from their inner experiences, or they might use substances to disconnect them from that, or they might be living very kind of avoidant lives, or they might have been taken out of life through physical illness or through changes in life circumstances for a while. And as they step back into those life circumstances, or as they learn not to kind of dissociate so much, or as they put their substance use away, almost certainly their symptoms are going to get worse. They're going to become more distressed, they're going to become more anxious, they're going to feel more overwhelmed. And if we're looking through the lens of symptom reduction, that's going to look like they're getting worse, even if they're actually making some great improvements towards kind of living their lives more effectively or making important changes. So it can be kind of misleading in both of those ways. Also, when we focus on symptom reduction, it kind of orients us away from other things that we might need to be focusing on. So if we're just focusing on the level of a symptom, it might mean that we're kind of not paying attention to other indicators that might be changing. So people might be showing great improvement in terms of developing new skills, or in terms of becoming kind of less avoidant in their day-to-day life. But those things aren't connected with level of symptom. They sort of happen independently of that. So the more we focus in on symptom reduction, the more we miss these other kind of clinically meaningful and important indicators of change. So there are also empirical reasons why focusing on symptom reduction can become problematic. So let's look at some of the empirical reasons now that can become a problem. The first way that can become a problem is if we look at the experiential avoidance literature. So experiential avoidance just means any behavior that we do which functions to alleviate some kind of inner state of distress. So these are the things that we do to kind of get away from our pain, to have less intense emotional experiences, or to have less kind of negative thoughts, or to be able to distract ourselves from them. It's a behavior that's defined functionally. So there's a lot of different things that you can do that might work as experiential avoidance. So if I was feeling socially anxious, I could have a few drinks before I went into a social situation to minimize my anxiety. Or I could maybe constantly kind of reassure myself or tell myself everything's going to be okay. Or I could distract myself by listening to loud music. All those kind of ways of minimizing anxiety. So different behaviors, but all with that same kind of functional purpose of eliminating some painful inner experience. If we look at the literature on experiential avoidance, and you can check out some papers, which I'll put a link to here, you can see that the more people engage in experiential avoidance, the more people kind of struggle to stay in contact with painful inner experiences, the higher their levels of kind of long-term disability and functional impairment are in their lives. And there have even been some research studies which have shown that really experiential avoidance is a major transdiagnostic risk factor for a whole range of different kind of psychological problems, and may even explain the kind of course and the course and severity of illness or psychological problems in a number of areas. So that's one kind of piece of the literature that shows that if we're focusing on experiential avoidance, training people and encouraging people to try and get away from their symptoms and make them less intense, that there may be some problems in that for the long term. The other piece to that literature is the thought suppression literature. So Wenslaff and Wegner's kind of famous white bear study, which sort of was a demonstration that the more people try and get away from thoughts they don't want to have, the more they kind of tend to have them in the long term. And there have been other follow-up studies based on Wenslaff and Wegner's model as well, which have also shown that even when you do try and suppress thoughts, you can kind of do it for a little while, but there tends to be a rebound effect, and you tend to have those thoughts more often and experience more distress. And even that can kind of roll over into other related thoughts as well. So you don't often have just the thoughts that you're trying to avoid, but you might also be more likely to have lots of other thoughts related to that as well. So taken together, I guess, we need to kind of be wary around how we approach therapy in terms of how we train clients, and the kinds of messages that we might be imparting about how people kind of relate to their inner world. And do we want to kind of be reinforcing this message that the best thing to do with your inner world is to kind of try and get away from the painful stuff and get towards the good stuff? So there's also other avenues of research, other streams of research that kind of have looked at this idea of why focusing on symptom reduction could be problematic. One of those is just research which has looked into what kinds of treatment outcomes people are actually interested in working towards. So there's been two interesting studies, Binder and Zimmerman, which I'll put down the bottom there. And these studies both kind of showed that when you actually ask people what kinds of therapeutic outcomes they found the most beneficial or that they wanted to work towards the most, that people are at least equally as interested in quality of life outcomes as they are in symptom reduction outcomes, the kind of feeling better stuff. And in fact, in the Zimmerman study, it was even shown that people in that particular sample had a greater preference for quality of life outcomes than they did for symptom reduction outcomes. So and it's really relevant for us as clinicians, obviously, because in the therapy room, we are asking our clients, what is it that we want to be able to work towards? What would you like to be able to work towards? It's interesting that question has been so infrequently asked in the research literature. Instead, it's kind of more assumed that what we're working towards is symptom reduction. Another area of the research is the kind of achievement-based literature. So the achievement-based literature, there's been some nice studies which have actually shown that people who frame their goals in approach terms rather than avoidance terms, so framing your goals in terms of what are the things that you're wanting to kind of work towards, as opposed to what's the painful stuff that I want to get away from, actually results in greater feelings of well-being, in greater levels of positive emotion, and in some cases even better performance. And that's even been investigated in a therapeutic context, which found that in a sample of depressed clients, that certainly people who framed their treatment goals in avoidance terms did not respond as well to the treatment and ended up being more depressed after treatment as compared with people who had framed their goals in approach terms, what they wanted to kind of work towards or have more of in their lives. So those are two other avenues of research unrelated to the experiential avoidance kind of research that are sort of also pointing in this direction that maybe we do need to be looking beyond kind of symptom reduction. Another interesting area of literature which looks at symptom reduction is the exposure therapy literature. So exposure therapy, which is probably arguably one of the most evidence-based practices in clinical psychology. And for years, exposure therapy, up until very recently, the most popular theories around how exposure therapy works and it works to achieve sort of symptom reduction. So somebody is in the presence of something that they feel very afraid of, or they've learned to be afraid of. By repeatedly exposing that person to the feared stimuli, the notion is that their anxiety kind of goes down. This was kind of the historical basis of exposure therapy. And it was thought that repeated exposure to the stimuli gets your anxiety to go down, and the mechanism by which it does that is anxiety reduction during an exposure trial. So if you can get anxiety to come down during an exposure trial or between exposure trials, then you've done successful exposure therapy. So symptom reduction in some sense was kind of the sort of yardstick to look at for how do you know if you've done a successful exposure session. Michelle Krask and her colleagues published some really interesting research and have done some great work in exposure therapy and have effectively shown that anxiety reduction during exposure trials or between exposure trials is really not a good predictor of whether or not you're going to experience anxiety later in the presence of that stimuli. And they've developed a model of inhibitory learning based on that, which is really interesting. You should check it out. So the notion, though, is that an area where sort of symptom reduction has always been kind of held to be important and been a mechanism by which exposure therapy works has now sort of been shown not really to be the mechanism by which it works. And even exposure therapy itself, which has always been targeted towards ultimately symptom reduction, getting people's anxiety down, is really now used in much more sort of expansive ways in third wave therapies like ACT. So not just to sort of get people's anxiety down, but how to expand and increase their behavioral flexibility in the presence of stimuli where they're not able to behave flexibly. Another interesting piece of research which is relevant to what we're talking about today is based on the assumption that you need to get symptom reduction happening before you can see changes in behavior. So the idea that symptom reduction precedes meaningful behavior change in therapy. And again, this is another one of those implied assumptions in clinical psychology that we need to get people kind of feeling better before we can get them doing things differently or experiencing more satisfaction in their lives. So when that assumption has been investigated in the research, a number of studies have looked at this kind of idea, and it turns out that you actually don't need to get the symptom reduction happening first. And in fact, Gloucester showed that in an ACT intervention, you can actually have changes in values-based behavior which precede symptom improvement throughout the treatment. And other studies have shown similar things. Increases in psychological flexibility have been shown to be kind of more predictive of later satisfaction in life than symptom improvement. And even in studies which don't directly target increases in values behavior, in a CBT intervention, Hoya, which is an interesting study to look at, showed that you can get symptom reduction and you can also kind of get changes in values-based behavior, even though it wasn't directly targeted, but that the changes in values-based behavior were more predictive of life satisfaction after the treatment than the symptom reduction. So again, this kind of just sort of draws that assumption into question. It doesn't say that you should never achieve symptom reduction before you can get behavior change. It just says that that is not necessarily the way that this has to play out, and that focusing in on behavioral outcomes may even be an efficient way of helping to achieve symptom reduction in the long term. Lastly, there's another line of research which I guess has looked at the concept of mental health. So for a long time in clinical psychology, there's been this assumption that mental health has really been defined as the absence of mental illness. So if you can kind of take away the mental illness, then people will just be psychologically kind of healthy. And researchers like Corey Keyes have kind of looked into this in a lot more detail, and really with this kind of asking this question of, well, is mental health or psychological health really just the absence of pathology or the absence of what you might call kind of symptoms or diagnoses? And this research has really kind of been interesting and developed what's called the two-factor model, which has basically showed that these two things are not just two sides of the same coin. So that when we work with our clients to reduce their symptoms or kind of get rid of their disorder, so to speak, that does not necessarily mean, even if we achieve that goal, that they will be then left as psychologically healthy, flourishing human beings. The skills of flourishing and being psychologically healthy and having mental health are completely different to the skills of reducing mental illness and getting rid of symptoms. So these things are independent of each other, which has kind of certainly shaped a greater, I guess, appreciation of the importance of working with clients towards prosperity and growth, and really thinking about how do we enhance behavioral repertoires in those areas of quality of life and well-being. And a number of branches of psychology now look into this. So in addition to sort of some of the philosophical and empirical reasons why we need to look beyond symptom reduction, there's also practical kind of clinical reasons that show up as to where symptom reduction can become a problematic focus in therapy. And one of those is that when we kind of focus on symptom reduction in therapy, if we think about what are we modeling or what are we kind of training or what are we shaping from our clients, we can sometimes unintentionally shape a particular kind of way of relating to their inner world. So they might start to relate to their inner world. If they see their inner world as being consisted of symptoms, then they might start to relate to their inner world in a fairly adversarial kind of way, or in a fairly selective way, where some thoughts are seen as kind of normal and some are seen as pathological, or some emotions are seen as normal and others are seen as pathological. And this can kind of create a lot of struggle for people. And even if you're working with someone and you get good symptom reduction over time, what can happen is if people do walk away from therapy with that notion, with that really internalized idea that pain equals pathology, or pain equals kind of, mental illness, then, what happens later on when they're living their lives and their lives unfold in a way which brings them into contact with more pain, through whatever life circumstance, through loss, through life changes, through failure or rejection or disappointment, they will come into contact with pain again. And if they're carrying this idea that pain equals pathology, then they're certainly going to struggle more with that in the future. And it can also create a kind of confusion as well. I mean, if we kind of adopt that sort of label of symptom towards someone's internal experiences, it's not uncommon for clients to become very confused about their emotional experiences. I've spoken to many clients over the years who will say things like, I felt kind of sad today, but was that normal sad, or was that kind of the bipolar, or was that regular sad, or was that like my psychological issue showing up again? So it can kind of create confusing sort of inner landscape where people try and make sense of their own experiences through that kind of lens of symptom or pathology. So I guess hopefully what we're talking about in this video is certainly not that we don't want to achieve symptom reduction, but that symptom reduction, if we focus on it exclusively, it can be a limiting framework in which to conduct therapy. And in some cases, it may even produce unintentionally problematic longer-term outcomes. And there are philosophical, empirical, and kind of practical reasons as to why we would want to look beyond symptom reduction towards helping people grow and expand behavioral repertoires that are going to kind of add to their quality of life, add to their levels of satisfaction and their levels of prosperity. So if these ideas are interesting to you or clinically relevant to you, then feel free to check out my website or my Facebook page, sign up to the emailing list, or watch out for workshops where we look at practical ways of kind of using these ideas in the therapy room with your clients. Thanks for watching.